Okay. We are. Apologies. Hello, everybody. And I think we are live on YouTube. Great. Welcome to the 30th meeting of the Alameda County COVID-19 Community Advisory Group. We are, let's see, our meeting is interpreted into Spanish simultaneously, and you can choose the globe below once I turn it on to select English or Spanish. Can I ask one of our interpreters to make that announcement, please?
Absolutely. Bienvenidos a todos ustedes a la 30ª Junta del Consejo Comunitario del COVID-19 del Condado de Alameda. Para todas las personas que necesitan interpretación, por favor, cerciórese de hacerle un clic en el globito que aparece en la parte baja de su pantalla y seleccione la opción de español. Muy amable. Muchas gracias. Back to you, Lauren.
Thank you. I'm going to start it now. Right. So we also have closed captioning and interpretation in ASL. So we thank our interpreters today. We encourage everyone here to speak slowly if you're speaking so that our interpreters can keep up, and invite you to put any questions you may have in the chat if you have them. So I'll turn it over to our one of our co-chairs and our public health director, Kimmy Watkins-Tart.
Good evening, everyone, and thank you for being here with us tonight. We have a few updates for you tonight. Hopefully, we also will have partner updates. I want to also extend welcome on behalf of my colleagues, Nestor Castillo and Greg Hodge. They could not be in the meeting tonight, but they are still with us in thoughts. This meeting, is an opportunity for us to have conversation and dialogue, ask questions, get clarification around things, voice our concerns and opinions. And I really encourage you all to don't be shy. You usually never are, but just want to make sure that you know that this is the space that we have created for us to share information, but also to invite your thoughts and your feedback and hear your questions and concerns about how things are going for you, for the communities that you're serving. I also want to encourage everyone to name your organization if you are here representing an organization when you speak, so that we not only know who you are, but also the organization that you're representing. We have one partner update that it was sent to us that Lauren is going to read, but I also invite anyone who is here to, after Lauren provides the update from the partner who sent in the update, if you want to provide an update on work you're doing right now, please feel free. When Lauren finishes up, I'll open up the floor. Lauren.
Thank you. So I just wanted to share that one of our CAG members, Joan Edelstein, who is a excuse me, a nurse who works with OUSD and has worked with the county before, just wanted to share out that she doesn't report on the Alameda County school nurses, but wanted to share that students are getting sick, with some districts reporting about 10% in absences. Students are coming to school sick, but there's limited testing and masking, which means they're being exposed daily, but it's impossible to follow up properly to have them mask after exposure. She said they've talked to their representative from the health department asking for masks to be reinstated in school guidance, and she's bringing that to the health department. We're speaking with, she didn't make clear which health department that is, but she so we're also speaking with the Safe Schools for All at CDPH with the state next week. The problem is that the CDC recommends and says states can be stricter. CDPH won't be stricter, but says counties can be stricter. Counties won't be stricter, but says school districts can be stricter. School districts won't go beyond what the county says. The county won't go beyond what CDPH says, and CDPH won't go beyond what the CDC says. We've lost primary prevention strategies due to fear of backlash rather than focusing on keeping our students, the pediatric public health population, safe. With flu and RSV, in addition to COVID, we need to be taking actions that protect the health of our children and the families with whom they live. School nurses have been very frustrated, but we don't expect anything to change unless we have the support of the community. She apologizes that she couldn't be at the meeting, but wanted to share her update and her, I guess, advocacy in that moment. Thanks.
Thank you for that. Other updates, and I'm certain that Dr. Moss will speak to some of the things that Joan mentioned when he provided his updates. But is there anyone else who would like to provide an update on the work you all are doing in the community, what you're seeing, you would like to share?
Hi, everyone. This is Noha. I guess I just want to piggyback on that last comment and just say that, we're definitely concerned about after the winter break. So if we're already seeing those kind of increases now before people start to do all mixing in the traveling for Christmas and New Year's, and then folks come right back and go right back into school. I'm a big proponent of the idea of extending the winter break a couple weeks so people can finish their transmission period before they go back to school. I don't have high hopes that that will be adopted, but I really cannot see an argument for not reinstating masks in school, even if it's just through the winter surge. So I know that several of us community doctors are planning on advocating with Oakland Unified on that. So whatever way that we can be helpful in that, we're definitely, open to doing that. I'm glad it's reinstated in shelters and in jails, but we need to be protecting our schools in the same way, particularly knowing how much mixing there is between the schools and the community and the communities and schools.
Thank you, Dr. Abalata. Anyone else? All right. I would like to now turn it over to our staff, our County Health Officer, Dr. Nick Moss, and Julie Williamson, the Deputy Division Director for our COVID Division, to provide updates.
Thanks, Director Watkins, and we'll touch on masking later in this presentation. So just a brief run through of our COVID data, and then we'll also touch on the other big circulating respiratory viruses right now. So COVID cases, and this data is already a little bit out of date, but these are daily reported, confirmed, laboratory diagnosed COVID cases. So you have to have a PCR or similar kind of test reported to the health department to show up here. And it's been a good marker for trends, but it doesn't include people who only home test. So the number of daily reported cases has just about doubled since mid-October, probably a little bit beyond that now. That was our low point, and appears to be continuing to rise. Next slide. And because we don't get every case reported to us, and there are many people who are never diagnosed, we look at other metrics. So we also look at test positivity, and you can see after some sort of gradual increases in November, test positivity really has increased more rapidly in the last couple weeks. And what you see in the blue line is the test positivity for the laboratory reported test for the county as a whole. And then the orange line is in our more disadvantaged census tracts using the Healthy Places Index. So test positivity a little bit lower right now in those communities. We often see a pattern where these switch in the middle of a wave, and we see it move. We see the highest case rates and test positivity move from more affluent communities into more into communities where there's much tighter housing, more frontline workers, things like that. Next slide. And hospitalizations have moved up quite a bit as well. We know that a lot of these, especially right now, early on in a wave, these are going to be mainly people with other diagnoses, but everybody is getting tested at the hospital these days. And so a lot of COVID cases identified there. It's and we're getting up to the kind of numbers we saw this summer. The intensive care unit's still not that heavily impacted by COVID at this time. Next slide. And lastly, our wastewater data is really showing a similar type of pattern with pretty substantial increases through November and really even more so in the last few weeks. Next slide. So COVID is around. We are seeing what is likely going to be our main winter wave. Hard to predict the future. We're at about 24 cases per 100,000 residents per day. This is reported laboratory confirmed cases. Still short of where we were this summer and well short of our peaks in past winters, but we are increasing. The other thing I wanted to highlight here is that we did move from CDC low COVID community level to CDC medium community level last week. That's largely driven by hospital admissions for COVID. But I think certainly reflects what we see in other measures. There's a lot of COVID around. Next slide. I wanted to share some data on bivalent booster uptake as we get into this winter wave. So overall, a little less than 30% of county residents who are over age 5, which was the eligible group until just a few days ago, a little under 30% of those people have received the updated bivalent booster, with higher uptake with people over the age of 50. It is still well short of where we would like to be, although we are doing better here than most other places in the state. It would be great if we had a little bit better protection going into this wave. Next slide. This slide is here to note that we see some of the familiar patterns in terms of lower uptake among some of our communities of color where we have seen worse impacts in terms of severe COVID throughout the pandemic. Next slide. Switching gears to RSV. These are RSV-associated hospital admissions at Northern California Kaiser facilities. The state publishes this data weekly. What you're seeing here is 6 seasons worth of data, and with this season in that dark, heavy blue line on the left-hand side. And so we have an early and very active RSV season. The last few weeks, some suggestion of a plateau, and there are other measures of RSV around the state that are also suggesting a plateau or even improvements. Maybe we're past the peak there. That would be good. This can really put both young children and older adults in the hospital with serious illness. It's something we see every year, but this has been a pretty busy fall for sure. Next slide. Likewise, flu has hit early. We're seeing a fair amount of flu here in Northern California, more so in Southern California. It's on the upswing. Can also put very young children and older adults in the hospital. We do have a vaccine for flu. I don't have data on it today, but we know we're actually seeing lower uptake of flu vaccine this year than we do in most years, despite the fact that it's a pretty good match, is our understanding. Next slide. So what can residents do? Well, it's really the same things that we have been saying all along. Staying home when sick, really important here. I think you heard in the opening comment from Joan Edelstein, people are going out sick. They're going to school sick. I'm in isolation for COVID right now myself. I've been barely left the house except to walk around it for the last 8 or 9 days. Stay home when sick. It's really helpful for other people and really important at this time of year. We know that's hard for some people for economic reasons and childcare reasons, but stay up to date on vaccinations. Really important. Got to keep repeating that message. Vaccines are really helpful here. Keeping gatherings smaller and outside or well ventilated. will help people stay safe. Wear masks. We'll get back. We'll do more on masks in a second. Test for COVID and have a plan for treatment. And some of you may have been hearing the state has launched a campaign messaging around COVID treatment, really underutilized. Next slide. So, so I heard the comments at the start of the call about masking. We have been asked about this a lot lately. We have been and continue to be aligned with the state on mask guidance. We are not departing from that at this time. I'm not aware of other jurisdictions really anywhere that have used sort of local health officer authority to institute mask requirements for schools or countywide. We've heard LA talk about it a little bit, but they haven't done it yet. You know, I understand that, you know, I think as many people in this group know, we are big believers in masking. Masking is a great and underutilized tool to protect ourselves and our communities. And we are really continuing to support masking. We right now have no plans to use a health officer requirement or order for masking in settings in Alameda County. There are some state requirements that have kicked in, and I'll summarize those. So at medium and high CDC COVID community levels, CVPH does require, and I think Dr. Avalada commented on this, does require masking in homeless and emergency shelters, and heating and cooling centers, and also correctional and detention facilities. The county facilities are also covered by a county facilities requirement. So we have messaged this out. We did a press statement about this last week, and we also elevated the fact that masking indoors is recommended under current guidance for vulnerable residents, their household members, and anybody who wants more protection, which is quite a few people here in Alameda County. And these recommendations will be dialed up if we move into CDC high COVID community levels. I think that we'll probably continue to hear other messaging on this topic. This is where we are today. Also, masking continues to be required in healthcare settings in California. Next slide. I did want to touch base that on the authorization of the updated bivalent booster vaccines for children ages 6 months to 4 years. This happened last week. And that means that now the updated booster vaccines are recommended for everyone 6 months and older who's due for a booster. Just a slight wrinkle to be aware of, because the youngest children have only really had an authorized vaccine for a short period of time. Some children are still finishing their primary Pfizer vaccine series, and they would actually get the updated vaccine as their third dose of that. So just a little wrinkle. The vaccine is expected to be available in Alameda County in the coming weeks. I don't have an exact date. And I think that's my last slide.
Let me unmute first. Thank you. Good evening, everyone. Thanks for joining us. I will do a brief update on just activities in the COVID division right now. Donata was not able to be here this evening, so I'm stepping in for her. Next slide. So basically, our surge strategies is similar to what we reported last time. Our COVID investigations unit, we're continuing to prioritize sort of the high consequence settings for our investigations. Right now, we have cross-trained all of our different investigative teams so that we can respond more quickly to those areas that are having more significant surges and outbreaks. We've deprioritized just some of our regular site visits. However, long-term care facilities do remain among the priority settings that we're responding to, investigating, and providing prevention services. Let's see, as far as vaccine goes, one of the things we just wanted to alert people to is that we have our stationary pod sites. We've reduced those down to 1 site a week. We're going to continue that through the winter. And what that means, though, by reducing that, we're increasing our homebound vaccination services, and we're also increasing our vaccination clinics at long-term care facilities. I believe we've done over 95 different clinics at long-term care facilities, and we've scheduled like another 50 to 100 coming up this month and next month. The other focus for our surge this winter is testing and treatment. And we are increasing availability of home tests at any of our community testing sites. You can get a home test. And our focus, again, for this winter is on uninsured and the underinsured populations. Next slide. Okay, so just a little bit more with this. We're continuing to partner with many of our community partners. So thank you for all of you that are participating and doing vaccinations and doing pop-up pods. Those are pods that are going to places where people are, at regular events or to other sites that more of our community members go to. We do have now, in terms of access to testing, we have an interactive community testing map that's up, and it's on our website, so you can access it there. And we also have our vaccination calendar, so you can see where there are scheduled vaccination clinics where people can get vaccines. Our prevention work is going on in all of our settings. We have been setting out guidance, providing technical support to different organizations, and particularly in our congregate settings. We've been working very hard to get information out to people. Next slide. And as you can see here, just, following on what Dr. Moss said, we're seeing a definite uptick in outbreaks in our long-term care facilities, very similar to what we saw last summer. We're sort of at that point, or actually have a few more right now. Next slide. And here, this is just a summary of our special settings. So this is looking at healthcare settings, at our homeless shelters and mental health facilities, as well as children, youth, and congregate settings, and in workplaces. And as you can see, sort of the majority of outbreaks are in workplaces, right? Well, they tend to be there throughout the pandemic, but we're seeing that as well. And there's a definite, more of a recent uptick. And actually, we are continuing to see upticks really in all of our settings and the number of outbreaks that we're experiencing. Next slide. So what I wanted to talk a little bit about, because one of the big issues, particularly for people in these vulnerable or that are more vulnerable to severe outcomes, we've been doing a treatment education and outreach pilot program where we have reached out to all of the cases that we get with people who are over 50 years old and that live in our priority zip codes. And those are in our more disadvantaged communities. Next slide. And I'm just going to briefly, we gathered a lot of data from this, but I'm going to summarize it very quickly. And I just want to talk about some of the things that we learned from this. We've reached out at this point, we prioritized 10 zip codes. And we did about anywhere from 100 to 150 cases were assigned to us per week, and we completed, roughly anywhere 50 to 100 interviews every week. All in total, we have interviewed over 1,200 cases with this study. So we reached quite a significant number of people, and that's about 45%, almost half of the cases that we received, we were able to successfully interview. The results of this is what we found is that roughly of the people interviewed, so of the 1,200 people, about almost 60%, 57% were eligible for treatment. We also found that over 67% of people were aware that treatment was available. What that also means is that 33% of people were not aware of treatments that were available, which is really a significant portion of those eligible. And finally, the reason we're lifting this up is because what we found is that of the people we interviewed, nearly 1 in 4, 24%, did express that they were willing to seek a treatment plan as a result of the interview. During these interviews, we did education about COVID treatment therapeutics, what was available. And they were overall very successful. If we could look at the next slide. So what we did to do some follow-up, so during the interviews, we found out people expressed a willingness to do a new plan. We did a small follow-up to see how many people actually did seek treatment as a result of these calls. And of the 42 cases that we followed up with afterwards, 74% of those actually did seek treatment. So that was really good news. And it was exciting to see that the outreach was making a difference and did have an impact. Next slide. So one of the things that, of course, we're really interested in are what are the barriers to getting treatment. And what we found from the feedback from clients who had already sought treatment prior to the call, so we continued the interview with those people. And 96 of those, they did not reported no barriers. However, almost 50 people, which is roughly a third of the cases, did report barriers to accessing treatments. So just to look a little bit at what these barriers are, next slide.
Thank you, Marcy.
So here's how the barrier sort of fell out. The 20 people of those 46 that we talked, or of the people that we talked to, there was a perceived denial of treatment. And this is where they reported that their provider either said they were not eligible or didn't need the treatment, or for whatever reason. So, and again, we say perceived denial, we don't know, we didn't interview the provider, so we don't know what they said. 10 people reported difficulty in finding a primary care provider or getting access to a provider. 8 people had difficulty actually filling the prescription. And some of that was that they had handwritten prescriptions and the pharmacy said they needed an electronic one. I mean, those are just some of the stories that were reported. Others had difficulty starting the course for a variety of reasons, and very few people had difficulty completing the course. So we wanted to lift this up just to show, we thought this was really interesting. There were some other results that we were looking at language access. And what we found is that when the interviewer contacted the person and spoke to them in their native language, and it was primarily Spanish, but there were also Mandarin and some other languages that we had interviewers could talk to people in. There was a 10% greater uptick in their seeking treatment or following the advice that they were getting. So there was we actually did see a difference in that. And it really does lift up the importance of language access and also the importance of having staff communicate, people who are doing education, being able to talk to people in their native language. Next slide. So just to lift up what we're doing, recognizing some of these barriers, we're trying to direct, there's a telehealth line that's now available. And so when they're unable to receive care from a primary care provider, we're directing them to the California COVID telehealth line. We're providing cases with printed materials to take to their providers at the appointment, just so they can offer additional information when they're having that conversation. We're providing trainings on treatment to our community partners. And we're also doing some medical provider education. We're looking at starting some of that. And we're providing feedback to both our healthcare and hospital systems when problems are reported. So we're trying to maintain those active relationships with the health system. So there's things, that we are doing to do this, but we thought this is a pilot study. We do plan to continue with some of these calls, but we wanted to just let you know that this is some of the strategies we're using to reach our most vulnerable, or those people who are vulnerable to more severe outcomes. And we are getting some positive results from that. Next slide. So here's just some information. I know the slide deck will be available afterwards, but there are some links and phone numbers you can use to get access, or if you have clients that need access to therapeutics, here's some strategies for doing that. And next slide. Finally, I think I just wanted to mention, as you know, we've stood up this COVID division. It's a temporary division within the Public Health Department. We plan to maintain our full services that we are offering right now through the winter surge. We've seen this coming. We're in the thick of it right now. However, beyond March, we will be doing some shifting out of the emergency response. There will be some downscaling, and we'll be integrating our support services into our communicable disease division. And I think as that happens, we're going to be working more and more and relying more and more on our coordination with our community partners and with the work that all of our community partners are doing and all of you are doing out in Alameda County is going to become more important. So right now, the other thing, and I think the discussion, and this is part of a tip off to where we're going to be going, is I think the future, as we look at living with COVID, since it's likely not to vanish, as was promised years ago, it is going to stay with us. So how do we change our social norms to learn how to live with this safely, reduce or eliminate any unnecessary or preventable mortality from COVID, and change how we move forward? So that is the focus right now. That's my last slide. And that's our update from the COVID division.
All right, thank you, Dr. Moss and Julie. So before we move on, want to pause and open it up for questions, comments from you all on either Dr. Moss's presentation or Julie's presentation.
Hi, this is Dr. Donna. Can you hear me?
Yes, we can.
Hi, I apologize for being off camera. I'm driving to basketball practice for my son. But I completely agree that our test positivity rate is higher in the community. And so many people that I know and contacts have COVID at this moment. And one of the things that I'm hearing in the community and seeing for myself are people who are not going in for a PCR testing when they have a negative home test. And I'm wondering if we can get some messaging around that from the Public Health Department, that if you have symptoms and your home test is negative, to follow it up with a PCR test, because I'm certain that there are a number of people who are walking around with a negative antigen test, but actually do have COVID. I have experienced it firsthand in my family and in my church family of people who have been negative with a home test. I've encouraged them to go get a PCR test, and it's been positive. So just hoping that we can maybe get some messaging around the importance of getting a PCR test if you are symptomatic, but your home antigen test is negative.
Thank you for that. And that's actually also a good suggestion for all of us, as we're all providers and we all work with people in the community, that we can also help to carry that message to our family, our friends, people that we're serving, that just as you did and are doing, Dr. Donna, but yes, we will also step up our information around the importance of, following up. And of course, just remembering too, that if you're sick, stay home. If you can't, and that's the caveat, we know that a lot of people do not, for, economic reasons, do not have the ability to stay home. Masking is really critical as well. And so, because there are two other things floating around, probably some other things, but we're paying attention to the three,
Right.
that are right in front, that we're all talking about, but there's quite a few things that are floating around. But, there's COVID, there's flu, and there's RSV. And so it's important for us to all stay very vigilant on our own protective measures and those old school, stay home, wash your hands, now covering up with the mask. And, you know, and we will also do what we can to also help community groups to get access to more masks, you know, to encourage people to wear them, please. They do work. They make a difference. Pastor Arlene.
Yes, thank you.
Yeah. Hello, everyone. Amen to what Dr. Donna is saying. We're noticing, you know, those similar kind of concerns as well. I just wanted to ask a question about, you know, just the availability of over-the-counter remedies for addressing some of the symptoms. It was brought to my attention by one of my employees who was out with sick little children that she didn't have any family daycare, so she had to stay home that day. And then her kids were super sick, and she had to drive to like 5 or 6 drugstores in order to find children's Tylenol. And that made me really concerned. She's a real savvy person, and you know, she has more resources than some of the people that we serve among and stuff, and yet she was pretty you know, concerned that she couldn't just get this basic acetaminophen for her kids. And I thought, my goodness, if she's having trouble, how's it going for the newcomer families, right? Terrible. So I guess my little story, I then called up Winnie Knowles and Julie Greenfield, you know, who are really wonderful pediatric nurses and friends of mine, and I said, this is anecdotal, but I think this might be a thing. And they were great. They both went out and started going to drugstores, and they found the same thing in other parts of Hayward and unincorporated communities and so forth. So I guess, you know, I didn't post anything on Facebook. I didn't want to freak people out about that, even though I was getting real concerned. And I just, you know, want to know, you know, I talked to a couple of pharmacists who told me they'd been trying for a week or so to order children's Tylenol, and they couldn't, nobody would even take their order. So anyways, my cousin Beverly, who's a nurse in Des Moines, she's like went out and bought $100 worth of that stuff and is sending it to me. But, you know, really, what are we going to do when my $100 worth of Iowa Tylenol is out? You know, where can people go? Where can we direct people to go to get, you know, even the over-the-counter things, you know, when the people want to test and they want to treat and they can't even buy it? Where can we send people?
Nick, did you want to comment on this as well as other clinicians in this space? I would invite you all to unmute as well to share some insights. We have been hearing that some shortages, you know, were occurring, but Dr. Moss, I'm gonna give you the floor first to comment on this.
Sure, and Pastor Arlene, I actually heard through, you know, internally through our staff about your I think that your question had made it to us as well, and I think it's very difficult. We're aware that, I mean, I've heard it from some places. I'm not hearing it everywhere, but I know it's true from personal experience. There's been a run on children's Tylenol and you know, all kinds of cold and cough medicines this you know, last few weeks, and yes, I mean, I think one answer is to scour your local drugstores, talk to them, ask when they're getting more in. You know, if you're a Kaiser member, which is like 40% of Alameda County residents, they have their own, you know, drugstores. It's worth checking with them as well. Their pharmacies all have a little drugstore you can get over-the-counter stuff. Then there are alternatives. I think it's worth talking. It depends on the age of the child. You know, for people who have a healthcare provider, it's worth reaching out to your healthcare provider and say, hey, you know, we can't get children's Tylenol. What else can we use for my child? It's not necessarily going to be the same for everyone, but there are things that can be used. You know, I'm not aware if anybody who works on the sort of emergency supply side of things on the call is aware. I'm not aware that the over-the-counter children's Tylenol or other types of over-the-counter medicines are things that we have normally distributed through the sort of emergency supplies process that we have. But if somebody knows otherwise, please chime in. And then, yeah, if other clinicians or others, non-clinicians have other solutions to this particular issue, please jump in.
I don't think we have anyone from our EMS team, or Donata, of course, is our resident expert on emergency, supplies and resources, but we will look into that. We're not sure if this is something that we even have, that we, provide and help, community members with, kind of thing. Are you like organizations and those kinds of things? Other thoughts about this, other comments for Pastor Arlene? So, someone was going to speak.
I just was going to ask kind of a related follow-up question.
Sure.
Like, if I could win the lottery and get lots of money to give this away, I mean, would it be okay to give out children's Tylenol through our food pantry or something like that? Or, I mean, I don't know. I mean, I'm just concerned. I mean, we've given out all kinds of other things, but we've never given out over-the-counter medications. But gosh, you can have, you can be on public benefits and then you still have to buy your over-the-counter medicines. And so that's
right. I mean, that would be true. Unrelated to the shortage, I think there are access issues there. I don't know what the regulatory issues would be. I don't know if you need any. I mean, you can buy that stuff at grocery stores and corner stores. So I think you can probably just give it away if it's not expired, and you have sort of, if there are any cold chain issues, you can sort of track those. And I don't know that there are. So my guess is that it's probably something that you can give away. I don't know if somebody knows.
Dr. Gock?
I think you're asking for trouble if you're giving away something that is even over the counter, with the possibility of a number of pills being taken, having an overdose, and the legal representation which that could lead to. Although it's nice to think about it, I would be concerned about that.
Well, and I know for children's Tylenol, dosing is really important, especially in the very, very small children, but it has to be factored by weight. And of course, having dosage information in the parent's language is critical. So I'd way rather see it being given out by community clinics than those of us who are, just doing the best we can.
But there's a difference in, protection. Community clinics have protection where you may not have that. And that would be
I'm sure my insurance carrier would hate it. I don't even have to call them. but
you have to get a rider. You can't say
for sure
of anything. We're not sure of anything with how people now go to lawyers to have stuff done for them, the minimal stuff. And you just can't, even though you're trying to do the right thing, you can't take that chance at this particular point in the way how people are so litigious.
I'm just hoping, actually, by putting it out there, I'm just hoping that the community and more of the experts can just know that's a challenge for a lot of our families. It's not just in the time of COVID. I mean, just having the basic things at home, how many families don't have a thermometer, stuff like that. So anyway,
I'm not trying to be really negative. I'm just,
no, I didn't hear that at all. I think you're spot on. I know that that's a concern, and
Now the other thing
that the people who can do that stuff will step up.
The other thing you can do, if you want to give them information about how to get the medications through Canada, they have no problems. I've had people ask me, and I've said, you can look and see it, just let me know if it works. But I'm not prescribing it. I'm just telling you another source. And yes, Canada does have a very fast return rate within a couple of days maximum if you give them a little extra money. Whatever the pharmacies are in those areas, or people who have that will get that to you quickly. But I'm not quite sure that that's an appropriate way to look at it. It is a way of getting It's like ibuprofen and acetaminophen.
Yeah, for sure. I mean, I've served on border states where seniors were going up to Canada from New York on bus trips. They drug holidays. They go up to Canada and buy affordable medications. So anyway, I've taken a lot of airtime, and I'm sure there are other people that need to ask questions too. Thank you, everyone.
Yeah, I see someone posted something from the Washington Post, one of our staff, regarding shortages across the country. And so we've all seen that one of the impacts of the pandemic in general have been supply shortages of lots of things, not just medical products. And so that still persists. And so, yeah, so this might be, a moment that we're in right now where there are quite a few shortages, but definitely trying to reach out to your provider to find other ways of handling symptoms and that kind of thing it's always advisable to try to talk with a medical provider or a medical provider, even if it's not your PCP, to try to talk to someone before, people making up their own solutions. That is the one thing that concerns me, that if people feel that they can't find something and they kind of create their own things, we just want to be very careful about that. So encouraging people to call, another provider, even if it's not theirs, if they have a call line or a nurse line or something like that, just to get some kind of medical advice is always helpful. It's better. Other questions, comments? Go ahead, Dr. Gott.
Okay, it's me again. What did Julie mean about medical provider education when she mentioned that?
So what I believe she meant was really convening our partners, medical providers, healthcare providers, who are maybe unaware of the fact that people are still getting misinformation sometimes from their providers, and making sure that they understand what the requirements are, what the eligibility is, that they have questions themselves or not. We can't assume that information, that there's a level, amount of information shared amongst all medical providers. And so I think that is what she's talking about, to make sure that they have the information that they need to provide their patients with the accurate information. Because when patients are saying, well, my provider says I'm not eligible, and we've been hearing that all along, not just from this pilot, and some of you have even shared with us that you've heard that from your community members who've gone to their doctors and been told those things. And so we do have to make sure that we all have the same information. So I think that's what she's talking about.
Okay, I just wasn't quite sure. Thank you.
Any other questions or comments? No. All right, so in this next segment, we're going to follow up on some of the dialogue we had last time regarding how do we really work together to shift the social norms, that we are where we are. And to Julie's point, COVID is not leaving anytime soon. And so how do we work together to really shift the way we think about this, and then shift our behavior accordingly as well, to keep ourselves, our families, our communities, the public at large, safe and healthy. And so I'm going to turn this over to my colleague, Ayanna Knowles, who is the manager of our Community Coalitions program, which sits inside of the Health Promotions and Community Partnerships Unit of the Public Health Department. I'll turn it over to you, Ayanna.
Thank you. Good evening, everyone, and happy holidays. My name is Ayana Knowles, and I am a part of the Health Promotions and Community Partnerships team. And just going to revisit our conversation from last month. Next slide, Lauren. Thank you. And for those of you who were with us, or if you weren't with us, just a quick recap. We had a few community partners talk about the successes and challenges, a little bit about the work that they were doing, the work that they have done during the pandemic. And as we've talked about here this evening, how are we moving from an infrastructure that is emergency response to setting up something that receives and sets us up in a way that we're uplifting community resilience. Next slide, please. And so our partners from the Serenity House, Tercio Vasquez and Umoja, we're talking about lots of things. And so a few of those things were messaging on materials. And so we heard you, Dr. Rhodes, and we understand, sometimes having the public health logo on materials and flyers can send a little bit of mixed messages to the community. And so we turn that into a new way. We have a set of materials coming out very soon that say funded by Alameda County Public Health Department. And so listening to the feedback that you all give us allows us to put that into the work in real time. Other things we talked about, how can we work towards increasing health literacy, that the message that how hard winter is going to be for the families. And so we're going to revisit some of these questions because we didn't feel like we had enough time to have a full and complete discussion. And so next slide, please. As we're thinking about preparing for the winter, as we're thinking about the successes and challenges and areas of growth that you all have as community partners, what are other ways that we can model behavior for the residents, for staff, so that we can show them that they're not alone and that we're here in service of them? How can we meet people where they are so that it doesn't come across that we are making decisions without their best interest in mind? How do we directly address distrust of the government? Are there other things that we can do in support of breaking down some of those barriers? Next slide, please. And so we want to continue that conversation. What can we, Public Health Department, and you all as members of CAG, do to change the social norms? How can we encourage positive behavior change, and what should we prioritize, especially now that we've had about a month of, of winter surge, of RSV, of flu? Even though RSV numbers are going down a little bit, we know and we've seen and heard that COVID is going up. I'm sure everyone, or most of us here have a sick person in our household or know someone who is ill. And so we just want to hear again from you, what are the things that we should be prioritizing now, or what are some things that are working well that you all are doing that we can support you with? And go ahead and open it up to the group.
Hey. Any thoughts? As the numbers are climbing, as people around us are getting ill, what kinds of things are you finding are working for you in the communities that you're serving to help people to navigate this new space that we're in, where everything is virtually opened up? There aren't the legal mandates restricting our movements and our behaviors. COVID is still with us. And now we're in I don't know if it's the middle, but we're at the beginning of a spike, of a wave. Are you experiencing things, seeing things that you're doing that you feel are working? We would like to hear you share a little bit. Yes, Dr. Abalada. And Lauren, can you take the presentation, the slides off so I can better see everybody? Thanks. Go ahead.
So yeah, I guess I'm just finding that people are getting the impression that it's over, or they really don't have an idea of where things currently are because they're just not being talked about. One of the things that's been coming up a lot lately is folks who have had COVID before and didn't die, and it's like, well, it's if I catch it again, it's not that big of a deal. And so I feel like one of the things that has been resonating and that I feel like has been getting people's attention is, that every new infection is actually an opportunity for another bad outcome. But also that, some of the recent studies that are showing that there's a cumulative nature to the harms of COVID with repeat infections. And so I think, wanting to not allow repeat infections to be so normalized, right? Because I feel like some people feel like, okay, I had it, and so I know what it's about. And so, I can go ahead and take the risk. And so I feel like that's one piece of it. The other piece, and I do find it fairly terrifying that we're, having shortages of over-the-counter medications. We had shortages of PPE when this started. We had shortages of all kinds of things. And the fact that we're 3 years in and having these kind of supply chain issues and things like that. So I think the other part of the conversation with folks is, it's not just COVID. We can prevent transmission of RSV, flu, metapneumo, influenza, and COVID if we do some of the basic things. And so, just kind of, I guess the other piece, and I got to admit, I've wrestled with this notion of masking season because I've seen some of the things that are coming out. And it's like, I would like us to be in masks until the pandemic, until it's more, predictable and we're out of the pandemic. But I also kind of understand why it makes sense to say, okay, I get it if you're not going to mask everywhere all the time, but during respiratory, illness season, can we all just mask? And so normalizing maybe like wintertime precautions, because then it gives people at least something they feel like they can look forward to, which I know is one of the hard things about what do you call it, like in perpetuity or mandates that or whatever, that feels like it's just going to be open-ended. So I do kind of like the idea of saying, and this is another thing that actually has been resonating as well, is that, when people talk about what plans they have and things like that, it's like, oh, maybe you can plan that during the low transmission season, and during the high transmission season, we're not like going to the spa or whatever other things that that maybe are, that where the risk changes quite a bit depending on the circulation. So I feel like that could be part of normalizing it also. But the problem with that is that it's getting harder and harder to know where things stand. I mean, just like the representative from OUSD relayed, that dashboard is no longer being updated. The testing isn't happening. So it's getting harder and harder to actually know when we're in those seasons or not. So I guess that would be my last thing I'll say, is that it would be great if there was a way for people to really know kind of what was going on. And I don't know if we've thought about putting the wastewater on the county dashboard, because that's becoming, a stark, like right now it's kind of going kind of straight up.
Right.
And I think that's helpful because some of the other things look blunted, because if you look at it compared to Omicron, it might not look very impressive. And so the average person isn't thinking about it in the same way, like with all the caveats that we might be talking about, like, oh, well, people aren't testing. The average person may or may not know that. So I do feel like very reasonable people that I know that we're always trying to be careful are right now dropping their guard because they legit think it's over because people aren't talking about it and everyone's dropping masks. And those people want the information. It's just getting harder and harder to kind of come by.
Right. Right. I want to just kind of lift up what you said in terms of making sure that the data and the information is available to people so that they do know where we are. And it is our intent to continue. We don't think that we're going back to the times where the public health department is not sharing any data with the public. We think that the genie's out of the bottle. We can't put it back in. And that we're trying to move forward to like, okay, how can we put more information and make it available so that people know what the situation is, and that when the community transmission is up, it is going to be up in those other settings as well, in schools, other congregate settings. So even if the school dashboards are not being updated, if the community transmission is going up in the broader community, it is going up there too. And so I like what I hear you saying, Dr. Avalada, that, you know, and that really speaks to how do we get people to start adapting to the seasonality kind of, and adapting our behavior, because it is probably unrealistic to think that people are going to stay masked forever and ever and ever. That is not realistic. But what is realistic though is when the numbers are going up, can we all agree that, okay, we need to mask up, try to stay out of crowds. Let's not plan the big stuff. And holiday time is hard though, but let's, you know, all the other extraneous big stuff, you know, let's not plan it in the middle of the winter kind of thing. Some things to think about. Thank you. Pastor Arlene, and then Carla Guerra.
Yeah, I just wanted to affirm the conversational style that Dr. Avalada is using. I think that's really helpful. As a pastor, I find sometimes the problems aren't about information, it's about formation. You know, how are we forming our sentences, not just what are we saying? And our, you know, I'm going to sound all churchy here, but I can't help myself. This is who I am. You know, are we speaking the truth in love, or are we blasting people with the truth? You know, and you know, I think, you know, for a, you know, a brilliant woman like herself, a physician, you know, modeling kind of everyday conversational style is really great. You know, I sometimes get up, especially like when I have a funeral in my church, and we have a lot of folks coming in and they didn't bring their masks, but it's okay, we're ready. Our greeters and ushers have them. You know, I just say thank you, you know, for, you know, wearing your mask today. And Eden Church, you know, mask, I wear my mask because I love you. I wear my mask because I care about you. I wear my mask because I don't want you to get sick. I wear my mask so that I can still go to the nursing homes and see our seniors who are so isolated in this horrific time. I hope you are. You know, I mean, you know, just, you know, it's so easy to go to the judgy, sad place, right? So I just think, you know, people that operate out of their head, you know, are gonna look at your groovy, amazing charts and graphs. And I love that stuff too. I mean, I'm fascinated by it, and I'm impressed that all this information you guys can generate, but just want to just encourage, especially, you know, in order to get the people in the middle, you know, I think it's our style. The medium is the message, I think, making it inviting, relational, kind, accessible. You know, I think that's really critical. And I have super smart people in my congregation around me, and I have people that maybe barely got third grade, but you know, we all can understand kindness and so forth. So just, you know, just some ideas, and you know, and people just acknowledging that people are weary of this stuff.
Yeah.
If worn down, it's just like, I want my Christmas back, you know, I want my holiday back, and empathy about that. And
Yeah.
you know, yeah, and you know, if you want to see grandma, you know, or so we can see grandma, we're going to do all these things because we don't want grandma to get sick.
Thank you, Pastor Arlene. Carla, and then Dr. Rhodes.
Hi there. This is Carla Guerra, Policy and Advocacy Manager at the Unity Council. I'm just sharing a comment on a personal level tonight. I am a chronically ill person, and just sharing, you know, my experience as a person at high risk of severe illness. I got COVID back in September, but for me, you know, it was COVID-19 pneumonia. a situation where, one of my lungs suffered 15% damage. And if I hadn't had access to treatment, my lung will have collapsed. So just emphasizing the importance of treatment and how effective it can be. I was so scared first because I had heard, of this COVID-19, like, I don't know if you call it the rebound situations, when you take a pill and then you feel better, the test comes negative, but then it comes back stronger. So I had heard about it and I was so scared to take it, but I gave it a chance. And guess what? It was a game changer. On the third day, most of my symptoms were probably, I don't know, just reduced on like 50%, I think, but still I had really severe symptoms and health issues for over a month. So what I would like to see in the county and happening, it's, continue that messaging on just giving treatment an opportunity, right? And then on a second note, keeping online platforms available for meetings, COVID-19 updates, or even social events, or have just some kind of hybrid mechanisms so everyone can participate safely. Some people are not ready yet to jump in on, in-person meetings or get-togethers, and I see those happening a lot, especially right now during the holiday season. But for the chronically ill, it's a choice between life and death. So just making sure that these spaces continue to be just shared, with everyone, and make sure that you can provide the spaces for people to join and keep themselves informed, but also safe. Thank you.
Thank you, Carla. Dr. Rhodes.
Yeah, thanks.
You're cut
I don't know
out.
if can you hear me?
Yeah, but you're cutting out a bit.
Oh, well, I may just put my comments in the chat because I'm having a tech problem.
Well, let's give it a try.
Oh, can you? Well, I just wanted to respond to this question about how do we get people to, I don't know, I guess roll with the kind of pattern of surges. And I guess what I want to say is more foundational than that. It's like, it is really about the way we talk about it. I think we've spent a lot of time trying to pronounce the end of the pandemic. Like, that's been for the last 3 years. It's like, okay, now we've got vaccines. Now it's going to be over. You can take your mask off, right? There's like, put your mask back on because it's serious. And it's like, okay, now you can take your mask off, even though we didn't really follow the criteria for unmasking. And so I guess it sort of pulls on a little bit of what Pastor Arlene was saying. It's like, it really is about how we talk about the pandemic, and to not be so deterministic about what we know, because we really, honestly, we don't know. And as far as long-term disability and long COVID and chronic illness goes, like, we really know close to nothing. And again, I always go back to this because I did do, basic work during the HIV epidemic and, characterizing variants, although they were not called variants at the time, but characterizing these different strains. That we've been with HIV for 42 years, and we're just now like at the point of kind of feeling comfortable enough to think we know what to do. Then we get to the equity issues, totally separate thing. But with COVID, we're sort of acting like we know when we actually don't know anything. And we're even talking about COVID in the same breath as flu and RSV because they happen to be happening together right now. But two of them are not impacting your entire body. One of them is. So I think the emphasis on the fact that it's going to be around, the fact that it cycles, and then the fact that we don't know what the long-term consequences are, like, it's just really honest talk about what we're dealing with. And again, to go to Pastor Arlene's comments, like, not to be judgy about it, but just to really be providing people the kind of information they need to make informed decisions about how they're going to protect themselves.
Thank you. Dr. Rhodes, I don't want to put you on the spot, but I have a question about, Dr. Noha Ablada brought up the issue of repeat exposure. And when people ask you, like, well, I've had it before and I was fine. And, what do you say to people when they say that? Because I've heard a lot of people say that, oh, yeah, I got it. And a couple of people I know, they got it a couple of times and they were fine. They didn't have any symptoms and they were fine. And
Yeah, I mean, I think the way I'm talking about it now, especially as we learn about what COVID is doing in our bodies, like even if you feel fine, like what are the parts of your body that have been attacked? You know, just to help people understand that it's not just your lungs, that the lock on the cell that spike protein is the key for. Those cells are in your brain. They are on your pancreas for the cells that make insulin. So you could end up diabetic later, even though you felt fine. And most importantly to me, they're in the blood vessels, which means that your blood vessels can be damaged in a way that can, you know, have you end up with high blood pressure, strokes, heart attacks, things like that. And sometimes I get into like, you know, imagine when the blood vessels heal, if they get damaged, when they heal, the way they heal is by making blood clots. So if you now have a blood clot, then whatever was getting blood, you know, beyond that blood clot is now no longer getting oxygen. And so all of your organs can be damaged. So I talk more kind of generally about, like, you might have felt fine, but there are things that this virus is doing inside your body that we don't know what the long-term consequences are. And to just remind folks of, if they remember this, in the beginning, these young people having strokes.
Right.
Right. That, you know, I just remind people, like, that's related to blood clots and to the way that your blood vessels function. And then I also did a lot of work in the lab, literally with my own hands, you know, growing those blood vessel cells. And one of the things I say is they're very finicky. They don't like to be disturbed. And if you don't feed them well, they turn into scar tissue cells. So this is what COVID can be doing inside your body, even though you felt fine while you got it. And then the other thing I remind people, because I heard it last night on the Emoji San Mateo meeting, well, I had it before, and so now I'm immune. Like, right. And then I just remind people, when BA.5 came, remember, it was infecting people who had just had BA.2 like 2 weeks ago. So we don't know if you're actually going to get immunity from being infected that will protect you against the next variant that's coming. And that's what's making this virus tricky, is there's a lot of different, you know, variations on it. So that, I mean, it's just to have like some back and forth and impart some information, even if it doesn't like change the person's mind, but just to expand kind of how they understand what's happening inside their own bodies. Because I think that's the big mystery. It's like, we think how we feel on the outside reflects what's happening on the inside. And for the most part, it does. But there are things that can go on that are silent. And, you know, in some cases, silent killers like high blood pressure.
Right.
Which is one potential long COVID outcome. So.
Right. So, and what I'm hearing both you and Dr. Abalada saying, and others saying, that despite the fact that at this point in time, all of us, I'm going to say all of us know someone who's had COVID. Okay. If we haven't had it ourselves, we all know someone. And I also hearing our clinicians say it's still worth it to try to not get it again. It is still worth it to not get it again. And so, because I have myself heard so many people, you know, say, oh, yeah, I got it before, no big deal, that sort of thing. And they're just not, you know, feeling that that is a big deal. And so I think for us all to be, you know, lovingly, as Pastor Arlene, you know, has said, you know, let people know it's still worth it. It's still worth it to try not to get exposed again, to try not to get infected again. We don't know actually what is going on. We don't know all of the long-term effects.
Can I ask, what is the strategy around communicating about long COVID? Because that is, I think, one way to bring the conversation, like to separate it from the flu. There is no long flu. There's, generally speaking, there's no long RSV unless you have like very severe lung scarring, but it's all about the lungs, right? What are we doing around trying to understand who in Alameda County is getting long COVID, right? Like, is there an opportunity for us to understand that and put that information out there? That, you know, right now in the United States, we think it's 1 out of 5 people who get COVID. So this time you got COVID and you feel fine and you think everything's fine, but the next time you get COVID, you still have that same chance of developing long COVID, which I don't think enough people really fully understand the debility. I mean, I think where we're mostly going to see it is in the shrinkage of the workforce, services you can't get because the place is closed because they're having an outbreak or because they've lost employees. The workforce is already shrinking. I mean, I don't think people are really understanding what's at risk here. It's not just the infection for those 10 to 14 days that you feel sick. It really is a long-term consequence. And for the kids, I'm really concerned because they've got a long way to go. And, you know, people with COVID, when they look at the brains on autopsy, they've lost brain tissue. I mean, this is not the flu. But I don't think we're like, I don't see where the messaging is on long COVID. And we did, Umoja did do the poster that went up on BART, and people kind of remarked, like, this is the first time I've ever seen any messaging around long COVID in public. And then when you think about it, that's true. It's that messaging is not out there at all. So that might be a novel, you know, approach to helping people understand what's at stake.
Yeah, I think you're right. And although we have, you know, provided, you know, of course, people information on it, I do not believe that it is fully integrated into like our messaging yet. But again, our communications team, unfortunately, is not here tonight. And so I don't want to misspeak, but I can bring that information back. But we need to definitely step it up because you're right, Dr. Rhodes. We need to really, you know, talk about it differently, talk about it more, put it more out there and distinguish it. Because you're also right that we are kind of conflating these things, even though they're happening together, RSV, flu, and COVID, they're not the same things. And really explaining how people, you know, explaining to people how they're not the same, how they are different things. And what is at stake and why it still matters to protect themselves. Yes, that's Dr. Road. Okay. Other comments? Dr. Gok.
Okay. You still have to explain things in language that are going to be acceptable. And a long, long time ago, I talked about the way COVID was first introduced and protecting yourself with mandates, etc., and how that turned a lot of people against even listening about anything more. And yeah, long COVID is very, very bad, but you got to get them first to even appreciate that there's a problem. If they get, I'll put in quotes, short COVID. And yes, you can get it again. No, it isn't exactly like the flu or anything, but when flu comes back, it's mutated usually some way, just the way the COVID itself has been mutated with all these various alphabetical types of messagings. And it still is a true need to find how psychologists, psychiatrists, people who talk to children can also get that language talking to adults so they'll accept it versus saying, you're trying to scare me, get out of my face. That's the most important thing for them to even get the first shot. And definitely now the boosters, because the numbers of boosters that are out there compared to some of the first shots, it's really far, far less, because I didn't get sick from the other COVID, and why should I get another shot? And although, yeah, you can't talk about it in the same way you can talk about flu, because flu is something different, it's at least something that people know about, and more people have had influenza, and more relatives have had that than probably COVID at this chance and time. But you can kind of link it in some way with how horrible you can feel. And sometimes that feeling can last for a long time. So it really is how you present it. And Pastor Arlene was totally correct. You can't put it in there as a scare tactic. It will work. They'll maybe still looking at you, shaking their head, yes, but their ears have turned off. And their brains. That's what pediatricians do a lot about, is how you talk to a parent. So they'll, you know, kind of do what you're recommending, and you talk to the children the same way. Is, you know that parent of yours is not your enemy. They're just trying to help you, and think about, well, how would you like to say it? Maybe if you get a whole bunch of people out there that you can interview and say, how would you say this? Help us, versus trying to just do it as a health department itself. And that might give you more information as to get a higher number of people who are going to actually say, yes, I'll get the shots or I'll get the boosters.
Thank you. And what I want to reiterate for all of us is that we are all of you, along with us, are leaders in our community. And most of you in here, in this room, have been warriors out there this whole time. And so we are having this conversation, not just for us, the public health department, employees, what we can do. We're also talking about what we will continue to do together, because we did this all together, all of us, all of you, all of us. And that will continue. You will continue to carry the message to your parishioners, to your patients, to your friends, your family, the people that you are educating. And we want this to be a place where we can share information about what works, and what works in one setting doesn't always work in another setting. And depending on who the messenger is and the time, and it's all very nuanced. And so it's important for us to continue to share different angles we use to approach people, and that we all do recognize the influence that we all have over a lot of people, and influencing how people think about things. That we should not take that for granted. Any of us should not ever take that for granted. And so I appreciate everything that you all bring to this work. And we launched this group originally to provide the public health department with guidance around vaccine rollout. We have since expanded to talk about all things COVID, not just vaccines. And we promised that we would always revisit and say, okay, do we want to stay together like this? Do we want to stay in this relationship in this particular way? We don't want to end any relationships. So I just need to underscore that. We do not want to end any relationships, but let's start thinking about, do we want to continue to meet in this particular format, in this particular way, with this particular content, scope, in the new year? We would like to continue having these meetings as we currently have them through the surge, through the winter surge, so that we can continue to provide you all information, continue to get information from you all, continue to work on this, because to Dr. Rose's point, we really need to talk about this very differently and not talk about it as we're rushing to the end. That's not a thing at this moment. It's not a thing. It's more like, okay, how are we living with this? And how do we talk about we're living with this? And how do we talk about this differently? So we are proposing that we continue to have these meetings throughout the winter surge, but during the months, we will probably likely ask you various questions about how you want to stay in relationship with us as a public health department, how you want to continue to work with us on different health issues, how you want to continue to inform our practice, how we want to continue our partnership, and then we will open it up for whether or not we continue this group after the numbers start to go down for this surge. And so that's just a forecast of what's in front of us. I don't think I see any other hands. Are there any final questions or comments?
Hi, it's Dr. Donna again. I have a question.
Sure.
And I did have to log off for a minute, so I may have missed this, but I know that OUSD is not updating their dashboard. So how are we going to keep our pulse on what's happening with our children in the county? And their rates of infection, and how to keep our kids safe. How are we going to understand what's happening with our pediatric population?
So I heard that earlier as well, and I don't have any detailed information from OUSD, and I don't know if anyone from OUSD is actually on the line that can speak to that in particular. So I don't presume to speak for them. But what we did say, Dr. Carey, is that one of the things, even if the schools are not continuing to update their dashboard, what we do know is that as the community infection has climbed, that has been the case inside of the schools. Schools were not immune to that. And so the cases are also rising there. And so we really want to encourage institutions that have power and authority to implement practices to protect their environments, that they consider those things. I don't have more to say than that. I don't, I'm not, from OUSD. And again, I don't know what's going on with their dashboard in terms of their plans to update it, to go back to updating it. I'm not sure about that. We will continue to keep track of COVID cases at a county level, at a community level. So we can have that. And that has not failed to be a good indicator of what is happening in other settings as well. And so I would, that is what we have now. And I think that we should use the data that we do have to inform our practice.
Is there a way on the county dashboard? Normally it says like less than 5 in terms of looking at COVID rates. And is there a way to break that down, even if it's, using another tab, so that we can actually see what we're looking at in our less than 5-year-old folks? Are they babies? Are they 6 months? Are they a year? Are they 3 years? It's all we're getting is less than 5 and then 5 to 11.
Okay.
Right. And so it would be nice to disaggregate that data a little bit more.
I'll take that back to our EPI team and see. I would imagine yes, but it might be a space issue. I don't know. I don't want to speak. I'll take that back to our team though. Your request.
Great. Thank you.
Any last questions or comments? Thank you, Pastor Arlene. Happy New Year. Happy holidays and Happy New Year. All right. Thank you, everyone, for your participation, for your attention, and for coming tonight. We look forward to seeing you all in the new year. Please stay healthy. Please stay safe. Enjoy your time with each other during these next few weeks, and we will see you all in January.
Thank you so much. Happy holidays.
Thank you.
Happy holidays, everyone.
Thanks, Public Health Department. We really appreciate you having these forums and giving us information and an opportunity to come together. So thank you.
Thank you, Donna, for being here. Appreciate you and all of you.
Thank you all. Thanks, interpreters.